the chain caught him and ripped the side of his nose out like that. You got to think of that.
Yeah,
It's so.
it was traumatic.
We can't see it now.
So I'm trying to put that in better paper and somehow.
Here's Brittany. Hey, Brittany. Can you hear? I guess you can hear us. Okay. Here's my twins. There's Macy. Say hi. Good. Melissa, Sarah.
Nancy
Here
is
she just
gonna,
posted.
she's going to be on Facebook.
Okay.
Since she was up all night. So she's gonna be
Okay. All right. Let's see. Brittany, can you say something just so I can see if we can hear you? If I have audio.
Hi.
Crap. Nope.
I'm gonna get it.
Let me make sure these are on. Let's see here. Thanks. Okay, there's that. I'm not muted. Okay, Brittany, you're muted right now. Unmute. Yeah, tell everybody to be quiet in your house. And then.
Brittany's quiet.
Yeah.
Sorry, my husband is playing music.
Crap, no, I can't hear it. Okay, let's see. What am I doing wrong?
Unmute, look.
Where?
Here.
No, that's Nancy.
Can you hear me?
Now I can. It helps when I turn on the speakers.
Can you hear me?
I can hear you. Yes.
Can you hear me, Dr. Neal?
I sure can.
How can I get my face on there? I don't know Lane's not here to help me tonight.
Uh-oh. Do you have do you see a little icon for video of the little recorder on the bottom?
Uh-huh.
Click on that video recorder. Where it said, there you are. Oh, I saw you for a second. And then it closed.
Oh.
Click it again. There.
Now,
Head.
there I am. Okay. Good.
There you are. Okay. And Desiree is on there too. Huh? Yeah, so you can take some money and go get a coat. Sorry. My girls just had teeth pulled and we've had orthodontic emergencies today, and so they're here eating macada in the back of the classroom.
It smells really good.
And I am going to open up, let's see. I had a couple things I wanted to go over, and I'll email you these forms. Macy, will you pass out, please give them those 2 sheets, and I'll email you. I think you guys may have had this uploaded somewhere, but it's pediatric labs. I wanted to talk a little bit, we can do whatever, but I wanted to talk a little bit about, go over some pediatric labs, because that was one of the things that you guys wanted to talk about. And then I have a PowerPoint that I cannot remember if we have gone over or not. So I'm just gonna pull that up real quick. Both of those. Yeah.
Those dibs on my computer.
Give everybody, just do that.
Everybody. Me.
Everybody.
And Sarah. All of us.
Give Melissa and Melissa, Melissa and Melissa
Yeah.
and Sarah.
Me and all my personalities.
Take myself, introduce myself. Okay. There's that. Sorry I was a few minutes late getting logged on, guys. We Zoom made me update from this computer, so. No, you don't know. Go eat. No. Yeah. Just everybody wants to know that. Did you have clinical today?
Have to be though, because she had an MRI of her knee. She keeps like,
Olga? You're talking about Olga?
Denise.
But she was back.
Yeah.
Okay.
Hold it together. I need you to hold it together for 6 months. That's what I need.
I'm scared for you to be with me anymore.
That's what Meredith said. I don't know if I want you. I guess you do.
Okay, well, I'm pulling up a PowerPoint real quick out of my Dropbox.
Can we see it on here?
Yeah, I'll have to print it on.
I can get my computer to work. It's fine because I'm sure she thinks so.
Okay. Yes, thank you for reminding me of that. I got to turn this on.
Yeah, Wyatt, maybe I bought myself a box cake so he could make me a birthday cake. We ate half of it before we could get it cool enough to do that. So it was
Nice.
It's called buttercream cake.
Yeah. Okay, so Desiree, I see you're on here. I'm not sure if I can hear you or not, but I do see you, and I think that's it. I think that's it.
Desiree wrote a chat for you on the side.
Oh, she did?
She's at work and can't talk, but she's listening.
She probably speaks Alaskan now, and we won't even understand her. We wouldn't even know what she was saying. Okay, so let me share my screen for a second, and when this comes on, share screen. Did you guys watch those? There's 2 videos that were under the infectious disease that were on viral infections, and one was under the modules. Like when you clicked on, there were 2 videos. Did y'all watch those? You haven't yet? Okay. I would watch those because they are really good. Brittany, can you see sharing my screen, this infectious disease PowerPoint? Okay. Awesome. And then I can make it bigger. There we go. Okay, have we gone over this PowerPoint? It's one of the things I wanted to know. Well, you wouldn't know because you can't see it because it's
We have not gone over bright ideas.
This is me.
Why is technology not helping me out today? I've done this before, and was it input source? Searching. Guys, I'm trying to get the computer to work. Hold on just a second. Possibly. I thought Haley might be here. No? I didn't ask anybody. I just said we would. Yeah, it's on. It's just not.
Keep searching for it and not finding it.
Yeah. Okay. I'm so sorry. Do either one of you guys have your laptops? I do. Can you log into that Zoom and so you can at least see the PowerPoint if this thing isn't working? So for you guys that on Zoom, I gave a handout here that has labs for anemias, and I'm just going to actually put it, we'll go over it in just a minute. I'll show it to you just on the screen, and then I'll bring it, send a copy through Blackboard. But I wanted to go over some of those just common pediatric labs and kind of discuss what we need to be looking at for CBCs. And Melissa, I had a nice, I haven't gotten labs back. Melissa and I had a really interesting case in clinicals, and haven't gotten labs back on that, but we had to look up some things as well. So you're never going to know everything. You're going to have to get out your resources and look up stuff. We had a child that we think may have renal tubular acidosis, possibly, but we're not 100% sure. But it was pretty cool. Yeah, it was really cool. But it's failure to thrive,
So we're gonna
essentially.
refer you to Sarah.
So we'll let you know. I'll
When you're
follow up. Okay, so let me go over this PowerPoint real quick. And before we start, do you guys have any, I know everybody's tired and busy and everything. Are there any housekeeping things we need to talk about? I've already started receiving some of your all's portfolios. How are the portfolios going? Great.
Overachievers.
Okay. So again, just send all those to me, and then we can, I'll forward them on. I think Dr. Roche is going to help me with some. Nancy and Brittany, are your clinical hours and everything going okay?
Yeah, mine's really slow though. The clinics are really, really slow this summer.
Yeah, so the
I'll
clinic,
see it.
yeah, my clinic has been very slow. I know that Melissa's, where she's at, has been slower than normal. So part of that is summer, just being summertime in pediatrics. Nobody wants to come to the doctor in the summer, and we're not having infectious disease season right now, so that helps a lot too. Hold on just a second, Maris. No carbonated beverages. Remember, after you get too cold. No, Pepsi is carbonated. Huh? No. Wait, that's tomorrow, honey. Yeah. Okay. All right. Sorry, we're trying to prevent dry socket over here.
You just said she can go get Coke, so.
I thought she might get a Gatorade. I have no idea, ladies, about this.
I'm sorry.
I'm so sorry.
That's fine.
Okay. So I have a PowerPoint on infectious disease. Stop me if we've already gone over this. Sarah, you're logging in? Okay. Well, this thing is useless, so I'm turning that off. All right. So I think from the case studies, you guys seem to be learning a whole lot about the different infectious diseases and kind of what to work up. And, you know, I wanted to talk about some of the most common ones. I wanted to see also what you guys think about fever in pediatrics and how are you educating your patients what do you tell them when they're concerned about fever? I get to pick on you too because you're here and you're up front.
Where's the Zoom link though?
Are we doing Zoom or is she just gonna
I emailed it.
You emailed it.
Mhm.
Okay.
Are we doing this? You want us on Zoom like too?
If you want, well, here, you guys can just
Or should we
look at
just
this.
do?
You want to just look at this?
Dr. Neal,
Yeah.
I just tell people that fever is a normal response,
Okay.
that we don't necessarily treat fever. We treat a child that may be experiencing discomfort from the fever.
Exactly. That's the perfect answer. And what I always tell the parents is just to remind them that, you know, if the child is uncomfortable, they're not going to drink. And so, you know, we worry more about dehydration than anything. So if they're not eating, you know, they're not going to starve to death if they're not wanting to eat for a day or two, but we need to worry about them not drinking. So we want to treat the fever and keep it down to where they're comfortable enough to drink and stay hydrated. And of course, when their fever, the metabolic rate is up, they're also going to lose more fluid that way. And so just overall, it's a comfort measure to keep them hydrated. So what is considered a fever? And on this PowerPoint, you guys can see over 100.4, and that's rectally or using a thermometer that has already adjusted if it's an oral or axillary or whatever. So 100.4 for most sources is what's considered a fever. So why is it beneficial? Why is fever good?
Your body's mounting in response to
Yeah.
Right. So fever, it helps your body respond to infection. It dilates the blood vessels. It increases the metabolic rate to where you're able to move all of those neutrophils and things and white blood cells out to the source of infection. And the main time we worry is one, if they have a history of febrile seizures. right? Because we know that if they've had a febrile seizure before, then they're much more likely to have a febrile seizure again. And really, febrile seizures themselves aren't that big of a deal, except if you're the parent, right? Have any of you guys, your kids or anyone had a febrile seizure? Or? Okay. Is it scary?
Yeah.
You're so laid back. I don't know if anything really stresses you out, but when it's your own child, it definitely is a scary thing, right? So, but that's part of the education you want to provide for those kids that, for the families who have already had a febrile seizure, that child you want to have more like diligent fever control with them. And then the other time when to worry is when it's not coming down. So I never really worry about the temperature as much as whether or not it's going to come down at least a degree after given an antipyretic. So if they give Motrin or Tylenol in 1 hour, it should come down at least a degree. Okay. So when kids are getting septic or, super sick, have a bacterial infection that's not being treated, usually their temperature is not going to come down with antipyretics. And so that's the other reason when we worry. Now that we have pneumococcal and Hib vaccines, we don't really see as much bacteremia. We used to just have fever and elevated white blood cells, and then we'd have to get blood cultures and all kinds of stuff. We don't really see that as much anymore, and most of that is because of the vaccines. So, okay, CBC with diff. How are you guys? How do you feel about interpreting CBCs? Good. Well, you're an oncology hematology nurse.
I'm used to seeing.
Yeah, as in clinical and so long. But
Yeah. So other than the oncology nurse, what about you guys in Zoom land? I can get them. Maybe not. Okay. So when do we need to get a CBC? Well, a lot of times we over check, and just remember that if we're checking a CBC, then that means that we either don't know what's going on or we think that there's some sort of bacterial type infection. And so we're trying to see how high the white blood count is. And so CBCs are really useful to follow infections. Like say somebody has pneumonia, you do a chest x-ray, do CBC, and their white blood count is, through the roof. And it's, 17,000. And then you want to give a Rocephin injection, start treating them appropriately, and then the next day repeat the CBC. And so we can use it kind of as a trend and follow the trends. Or if they have a fever and you really don't know what's going on and no other symptoms. Okay. So, other than that, we don't need to get CBCs. It's different if you've worked in the emergency room, kind of everybody gets a CBC. And, but, in primary care, if you have a healthy, let's say one of my kids comes in and they've had a fever for 2 days and maybe a sore throat or a little, just not feeling very good, something tired, whatever. And maybe we don't see a source of infection. We really don't have to do a CBC because we're just it's been 48 hours and this is still in that normal, viral period.
It's been 5 days.
Right. So if it's been 5 to 7 days, fever without a source, then we're checking urine, we're checking the CBC. But a lot of times we do unnecessary CBCs, especially in little kids when we know almost, the majority of the time it's going to be a viral illness. But if there's any concern, confusion, you can always get a CBC and just see what the trend is. So the key point to looking whether bacterial or viral is to look at that shift to the left. And so whenever we have a bacterial infection, the neutrophils, which if you remember, the neutrophils are the first line defense. They're the first responders. And so those are the soldiers that go out first. And so with the bacterial infection, you get kind of that quick, rapid response, and the neutrophils will shoot up. And this is on that handout too that I gave you guys. It's somewhere on there. And so if you see an elevated neutrophil count, and often the bands are elevated too, and bands are just going to be those smaller, immature neutrophils, white blood cells, then that's what's considered, quote unquote, the shift to the left. So we just want to make sure that we know how to interpret that and just that terminology when somebody says, okay, we got a 17,000 white count with a shift to the left. That just means that there's more increased immature white blood cells that are normally not there. So we think this is an acute bacterial infection. So with a virus, what does a CBC normally look like? The total white blood count is what? High, low, normal?
It's usually low.
It's usually low, yeah. It can be normal or it can be low. And what do we normally see? Which type of white blood count, or what percentage of the WBCs, which one is usually elevated with a viral? If something's elevated, you'll see lymphocytes. So if you normally will have either a normal or a low white blood count, and then the lymphocytes will be elevated with a viral infection. Okay, and so on this PowerPoint, and I'll post it if it's not already on there, this YouTube video is like literally a 4-minute little clip on interpreting CBCs, and it's basically talking about the shift to the left there. So other things that can cause an increase in white blood count, steroids can, and then also sometimes mono. I know we just had a good presentation on Epstein-Barr virus. But I remember one time in clinic, I had a child that had a fever for like 7 days, and I did a CBC and a monospot at the same time, and the CBC was like 22,000, but the monospot was positive, and so it was really kind of confusing because you would think with it being a virus that would be lower, but mono does some funky things to a white blood count as well. So those are the main things that I look at as far as the white blood count. Okay, and then C-reactive protein, we normally, in a viral infection, this is very uncommon to have an elevated C-reactive protein. So if we're worried about an osteomyelitis or cellulitis or some sort of, significant bacterial infection, sometimes a CRP is a good diagnostic aid to make, to help you determine if there is something, an acute bacterial infection going on. Also, if it's elevated, then just like saying what you can watch the CBC, the white blood count go down, and you can watch the CRP go down as well. Okay, and so I put right on here, it's uncommon for a viral infection to cause a C-reactive protein greater than 10. So if normally, if you have an elevated CRP, most likely over 10, most likely there's something bacterial going on. So what's the difference between this and a Sed rate? As far as when do you see these ordered versus like a Sed rate, or do you?
Sed rate has inflammation, right?
Yeah, and I mean this is, and the CRP does too, but the Sed rate is a slower response. It elevates slower and it goes down slower, and so Sed rates are a good marker for like autoimmune disorders and chronic inflammation. So a lot of times if you're thinking somebody has some sort of autoimmune dysfunction going on, you'll get a CBC and a Sed rate to look and an ANA or something like that to see if there's some inflammation, versus like an osteomyelitis where a CRP would be more useful. Does that make sense? Okay. And again, you'll have all these you'll have this PowerPoint on there. So again, Sed rate, if there's a Sed rate that is below 10, it's most likely not bacterial. So it's one of those things you can kind of rule out. If a fever of unknown origin, if you get a Sed rate CBC, Sed rate CRP, all those they're non-specific measurements of inflammation. And so a lot of times you'll see both. But you look here on the last point, in rheumatology or in autoimmune diseases, a Sed rate greater than 100 is common. So we're talking like 10 times higher than that cutoff. So anytime if someone has, chronic joint pain or inflammation, a Sed rate is going to be what you want to look at. Okay, and then this is just talking more about infections. All right, so I want to look at some of these specific viral illnesses. Right now, are you guys seeing any hand, foot, and mouth? They had several at my clinic. Are you guys seeing much Coxsackie virus? What about you at home? Are y'all still there?
I've seen it at Dr. Swade's office, and I have also seen it at Reliant as well with Emily.
Okay.
Not just this summer with Dr. Swade at the beginning of May, but with Emily last season.
Okay. Well, summertime is one of the key times for hand, foot, and mouth outbreaks. And part of that reason, I think, is just because it's fecal oral transmitted. And so kids are outside, they're in swimming pools, they're in diapers and swimming and doing all kinds of stuff. And then in fall, when we're back to school and daycares and everything. So I have a couple pictures on here. This right here is a good picture of the Coxsackie virus. And I just wanted to point out, like for boards, if you see the terminology herpangina, basically that is just hand, foot, and mouth disease without the hand and feet. So this is just the bright, it's usually a bright red throat with those kind of grayish ulcers on the back of the throat. So you may see that terminology is herpangina. And then versus, it's wonderful when they have the little blisters on their hands and feet because that's pretty obvious what it is. So
The throat starts first. Right?
yeah, the throat usually starts first. And then on this picture, I really like this picture. If you can see that little thumb on the bottom right box there, that's a lot of times they'll get those from sucking on their thumb. So that's a viral infection part from coming out there. So this is an enterovirus. Enteroviruses are almost always kind of a fecal oral transmission. So, but older kids will get this, and then of course it runs rampant through younger kids, and then adults can get it as well, and it's like a miserable sore throat. So how do we treat this? Same thing as far as with fever. They have to be comfortable, so they'll drink. So a lot of times, in addition to ibuprofen and or Tylenol, I will prescribe like a magic mouthwash. And a magic mouthwash is like Maalox, Benadryl, and viscous lidocaine. And you can find, protocols and things for that, how to mix that up. But the main concern is dehydration with the Coxsackie virus. And it'll go away. It's viral. It's self-limited, but it is really uncomfortable. And then this is our classic herpes virus. And remember, any herpes virus is a lifelong infection. So whether it's HSV1 or HSV2, they will come back during times of stress or decreased immunity. And Epstein-Barr is a herpes virus, Roseola, Varicella, and then HSV, cold sores. All of those are all in that herpes class. So you can see this is a good picture of little herpetic blisters there, and they're fluid-filled crusting. Do you guys see, have you seen chicken pox much in clinic?
No.
Yeah.
Since the immunizations.
Melissa, there's a slide before this on Coxsackie virus that had hand, foot, and mouth, and so you can look at that. And then herpes virus. Yeah, so I didn't see any varicella for probably the first 10 years of practice, and then I've just now seen little crops of it here and there. But varicella is a herpes virus as well. So that's just a good picture of herpetic blisters. I know we just had a presentation on Epstein-Barr, so I won't talk about that. But if you guys have clinical questions or test questions or anything, if they mention fatigue in there, that's like a ding, ding, ding for mono, okay? Because the strep ones, normally they'll say beefy red oropharynx, fever, anterior cervical lymphadenopathy. But when they have that fatigue in there, then read carefully and make sure we're not talking about a mono infection. And a lot of times mono will present and look real similar to strep, but of course the strep will be negative. And have we already talked about, did we talk about why we don't prescribe amoxicillin for negative strep throats? Have we
If it is mono, that's
Yeah. If it
Yeah, we did.
Okay, good. Okay, thought so.
Yeah.
All right, so
That's
Rosie,
bad.
that's bad. Don't do it. Okay, so, and Roseola, again, this is a herpes virus, most common in kids 6 months of age to 24 months. So we have that sudden onset of fever, and the fever goes away, and then they break out in this rash. Usually the kids do not seem like toxic. They're not like critically ill by any means. Usually Tylenol, ibuprofen will take the fever down, but anytime you have a 9-month-old with 104 fever, parents are panicking. So this would be an indication of when you could do a CBC, and you could just kind of wait and look at, if it looks viral, then we say, you know what, they're probably going to break out in a little pinpoint pink rash tomorrow or the next day after the fever's gone. So that's Roseola. And then Varicella, we have our classic, highly contagious chicken pox, and we don't see much of it anymore, but we are starting to see some again. And when is the chicken pox booster? When do we give a booster now?
I
Anyone?
should know.
When did we do this?
I know, I've been doing a
9
little
months?
bit.
6 months?
So we do
We
chicken
did.
pox at 1 year of age.
Okay, I remember we did another one, haven't we? We did.
And at kindergarten shots.
Yeah,
Uh-huh.
kindergarten, yeah. So it's 1 year.
Yes, and then if they haven't had one, they need one at 11. Because for a while there was a group that had missed that, so a lot of times we'll have to do that booster. But yeah, so you'll get the MMR and varicella, and then you'll get the booster with the kindergarten shots too. And again, remember acyclovir, as long as it's within that first 24 to 48 hours, you can use that. However, after that, just like for the flu, it's going to do nothing other than probably cause a little bit of bellyache. So once the virus has shed, then there's nothing that you can do because it's already replicated enough that the viral load is high. So, people always want antivirals after that window, and it does absolutely no good whatsoever. So flu, we all know about that, so I don't need to talk about that. But that is on here as well. And then, let's see here. And now I can see y'all's faces. Lovely. Which one, who did we have a presentation on anemia by someone, didn't we? Or was that last semester?
I did one last semester.
You did last semester.
Case study. So
We had the case study. Yes. So, Brittany, Nancy, and Desiree, there's I gave out a little handout.
This week's case study?
No, this week is infectious disease.
This week's infectious disease. It's fever, isn't it? I have to look again. So, we had a case study on, let me see. So this is what it's going to look like. Do you see this? Iron deficiency anemia. All right, Brittany, can you see it? Okay. I'm going to upload this. Most of you guys did well on that case study, but I wanted to point out just, as far as testing purposes and things like that, a couple do not forget items on anemia. When do we always need to check hemoglobin and hematocrit? What age are we?
12 months.
Yeah.
12 months and 2 years. So 12 and 24 months. Okay. And during that age group, a couple people forgot to put this one key point in. What is the biggest risk factor during that age group for developing iron deficiency anemia? Too much milk. Exactly.
Milk babies.
You will see it over and over and over again. And so when we do, so on those babies, if they're anemic, a lot of offices have a hemoglobin, or you can just check their hemoglobin. But we need to go ahead and get a full CBC and check. And that's why I gave you guys this little handout. So when we're looking at anemia, in iron deficiency, this is the most common one you're going to see in peds. In adults, we have, anemia of chronic disease, we have pernicious anemia, we have a lot of anemias. But luckily in kids, we just need to kind of understand this iron deficiency anemia. So when we draw their blood and look at their CBC, hopefully everything's nice and normal, except their hemoglobin and hematocrit are going to be reduced. And then their MCV, the mean corpuscular volume, is going to be low. And that's because iron deficiency anemia is a microcytic anemia. So the volume in the red blood cells is going to be lower. Now, one thing I wanted to point out is a lot of times you have those milk babies that aren't quite anemic yet, but when you check their CBC, their MCV is low. So everything might be normal except their MCV is low. And so what we can tell them is that we're on the way to iron deficiency anemia, because when we look at their cells under the microscope, that they're seeing a smaller, a microcytic, and lighter. So that last line on there, hypochromic, that just means they're pale. So we're having pale and small red blood cells, and we're on our way to having a lower hemoglobin and hematocrit. So looking at iron deficiency anemia, if you see the TIBC there, I don't know if you can see this at home, I'm sorry. The TIBC, that's total iron binding capacity. And that's going to be elevated in iron deficiency anemia, and that's really the body's way of kind of adjusting itself to try to bind more iron. So we're not getting enough iron in the diet, and so the iron binding capacity increases to try to, during times of low iron intake, our body tries to absorb more, okay? So that's just kind of a cool thing that happens. And then, of course, platelets should be normal. White blood count should be normal. And if we ever see everything low, then Melissa, what do we worry about? We're going to worry about leukemia first.
I was like, I don't know.
If everything is low, so if their platelets are low, and that's an isolated thing, then that is thrombocytopenia. And then what kind of things do we worry about with low platelets? If everything else is normal on a CBC, except their platelets are, instead of 150 to 450, let's say they're 70 or 50. What do we worry about with that?
DCIS?
What did you say?
DCIS?
Yeah.
I've heard about bleeding disorders like hemophilia or something.
Yes, but a lot of times the platelets are normal in those. Brittany, what are you saying?
Is it
We're talking about DIC?
DIC? Yeah, sorry.
I was like, what is he?
Yeah.
I thought you knew something
know
maybe
what
I
I'm
didn't know. I'm like, wait a minute. I wasn't prepared I didn't know what that is. Well, normally with that, if you're in DIC, everything's going to be just wacky normally. So I'm saying like a healthy child that we see, everything's normal on the CBC except the platelets are low. Usually that is, I think somebody did a case study on, did somebody do one on ITP, idiopathic thrombocytic purpura? Did somebody do that? I can't remember. Where everything is normal except for the platelets. No, I might be imagining that then. There's a couple illnesses that will cause the platelets just to drop. Have we not talked about that yet? Okay. You guys need to look at ITP then, okay? And that will be, and your book covers that, as well as the that little protocol booklet too, that has the decision making tree. There's some in there too under looking at CBCs. So the platelet count, if that is bottomed out, and a lot of times that is just an idiopathic, or it's where basically the immune system kind of reacts against the platelets and will drop. A lot of times it follows a viral illness, but it's fairly common in kids. And so I've seen one time I had a little maybe 3-year-old that had bruises on her back, kind of in some atypical areas. It didn't look like the normal toddler bruises on the legs and elbows and things. And so I did a CBC, and her platelet count was 4. Not 40, not 400. And so I wanted to put her in a bubble and send her to Children's. But she was like perfectly fine. Like dad didn't have any clue what was going on, just said she was bruising more than normal. So the good thing is it wasn't leukemia. Everything else was normal except her platelets were super low. So read about that. So that would be for just for low platelets. What if
Was her name Caitlin?
I don't think so.
Oh, okay.
I don't know.
I had one at Children's. Her name was Caitlin, and
Really?
yeah, she was admitted for a few days, even for the workup Dr. Pace did a workup.
Maybe so. I don't know.
I
This has been a long time ago. I
Yeah,
don't
it's been
remember.
10 years ago.
Oh, well, it may have been then. It freaked me out enough to where I still remember it, like 10 years later.
That's a freak out.
But I think that's the only time I've seen it. That's why I guess
That was super, that really scared me. So if the total white blood count is low, we worry about immune deficiencies, IgA, IgG, hypogammaglobulinemia. It's a big long word for that. But when things are low across the board, then that's called pancytopenia, and that is never a good sign. That means that the bone marrow, something is not working in the bone marrow, and that's a bone marrow failure. And so when we have low platelets, low white blood count, and low hemoglobin hematocrit, that means the red blood cell line is not being produced adequately, the white blood cells are not being produced, and the platelets are not being produced. And so often that's going to be like a leukemia. So that's an emergent. Is that not how most leukemias present?
Elevated white count.
Yeah, so a lot of times,
Elevated white counts and then everything.
yes, so the WBC can be super, super low, or they can be like crazy, crazy high in cases of leukemia. So, and those are, so basically the bone marrow is crowded out by immature, non-functioning white blood cells. And that's usually they're blasts, which are, we never want to see blasts out in the peripheral blood.
Yeah.
So,
Or when they do the bone marrow.
or the bone marrow aspiration.
Blast.
Yeah.
So that's how they just monitor.
Melissa, have you noticed working in oncology if, depending on how advanced like their leukemia might be, whether or not the WBCs increased or decreased?
Not usually. It just, because I've had some come in very, very sick, and it seems to be kind of across the board. I mean, it just depends on their symptoms. Like,
Okay. I was just curious if they were more advanced and their immune system's bottomed out, like, you know what I mean?
it's not a stage thing. Leukemia is just leukemia, you know?
Okay. Yeah.
It's like, we don't know how long they've had it necessarily.
Right. Okay.
But most of them present with fever, achy bones, pale,
fever,
bruising.
Feel like they've had the flu. They're usually, around 5 or younger, 3 to 5.
Yeah.
But we've had quite a few teenagers lately.
Really?
And weight loss, like unexplained weight loss and night sweats. I would say they talk to. And then we do their CBC, and you're like, whoa.
Yeah.
So,
Okay. So that was kind of the CBC in a nutshell. I mean, as far as in clinical practice, those are the main things that I've used CBCs for, looking, for infection, and then so make sure we can interpret viral versus bacterial with the CBC, looking for iron deficiency anemia, and then of course looking for any type of bone marrow failure, and then also with the low platelets too, for bruising and things. So, what else? What questions do y'all have about labs? Everybody seemed a little like not great about labs. one of the times that we met.
In primary care, that's mainly the ones we look at, right?
Yeah.
And then everything else
Mhm.
you're gonna send out and they're gonna interpret it, right?
Mm-hmm. Yeah.
I think it's overwhelming when you look at it like a big book and think, oh, do I have to do all of that?
Yeah, you don't do, I mean, really in peds, we're really lucky because we don't do a lot of labs. I mean, other than, your,
I guess bilirubin is another,
okay.
like when to keep on and when not to, you know?
Yes,
And,
let's talk about that. I'm glad you said that. So, okay, so let me ask you guys at home too. How often have you guys seen many elevated bilirubins in clinical practice? Okay.
I was trying to think of the other thing we mainly see, and that's that.
Okay. So bilirubin is bilirubin is normally elevated days 3 to 5 is when you're going to see the peak bilirubin, right? Should not be elevated ever before 24 hours. But that day 3 to 5 is like a catch-up time, and we're basically trying to feed the baby enough and get enough sunlight to where they're able to break down the bilirubin and get enough food in the GI tract where they can poop it out. So our breastfed babies are the ones that are notorious for getting jaundice and having elevated bilirubin. So that's another thing that has changed over the years since I've been in clinical practice. We used to panic a lot about elevated bilirubins. Now it seems the trend is to be a little bit more lax as long as it is coming down. So what I have been doing, there is an app on my phone or on phones, smartphones, that I have on my phone that is called BiliCalc, and it's free. I think it was free. If it wasn't, it was maybe $1 or something. But, the bilirubin, you're always going to have to look up. There's no way you're going to remember the guidelines and cutoffs for when we need to start phototherapy and when we need to transfuse. I've never, ever had to send a baby for transfusing. Had to do Billy lights, a lot. But again, that's gotten less and less over the years. Now, at Baby and Company, where I do PRN work, everyone breastfeeds there. There's a lot of jaundice babies. And, a lot of latching on problems and things like that. So the way that those numbers are calculated is by how old the baby was. So if they were premature versus full term, you have to put that in. And then you have to put how many hours of age they are. So it's a big difference if they're 36 hours versus 48 hours of age. And then you put in their bilirubin. And based on that, it's going to tell you that they're low risk, for serious complications, medium risk, or high risk. And so, and it'll tell you at what point you need to, for example, a full-term baby who is 48 hours old, it'll tell you exactly what point you need to start phototherapy. But you're not going to be able to remember those. I've never been able, because it's
You tell them to come back, like, how
so
quickly?
yeah, so what I do is and actually I read yesterday guidelines have changed where they recommend a Billy screen at every newborn visit. And I've never done that in the past. So that's a new thing. I got it on Medscape. It was, I don't know, I guess it came from AAP. But with those recommendations, that means we should be doing like a flash bilirubin on every newborn follow-up that we see. Because, a lot of these babies are going home and you're going to see them you're going to be the only person that sees them, especially if they go home at 24 hours or something. The ones at the birthing center go home after like 8 hours. And so a flash bilirubin, I guess we're going to have those at all of our offices where we just do the, little quick flash bilirubin. Those are a screening tool though. So we need to remember if that's elevated, you do have to poke them. Okay. So want to do Billies on everybody. Now that's changed because before it's always just been if they were jaundice. Right. And so then, basically if it's elevated, but not to the point where we're starting lights, you're going to recommend that they are going to keep them unclothed or as much skin as possible showing, and have them in front of the window getting light, because the UV light breaks up the bilirubin. And so we can get the bilirubin broken up and void. So we also need to be pumping them full of breast milk. The lactation consultants are not going to tell them to supplement, but depending on where you are and what you're doing, I tell them to supplement with like a syringe or something if they're worried about nipple confusion.
The hospital changed, I don't know when, but it's Alimentum. It's the
Alimentum, right.
the main, whatever, used to be kind of whatever, but now they're making them all do Alimentum.
So if you do, so if a breastfed baby has to be supplemented because maybe mom's just not producing enough milk, or what, they've gotten too far, the higher their bilirubin gets, the tireder, more fatigued that the baby gets, and so they won't wake up to eat. So if the Alimentum is hypoallergenic, it's broken down more already like breast milk. And so it should not mess up breastfeeding. And then there's all kinds of, ways that you can not give the nipple if they're really opposed to the nipple. Mom can also pump breast milk, and you can put it in a syringe and feed it to the baby, so we know exactly how much they're getting.
I've got to keep pumping.
Everybody.
I think sometimes I stop
oh yeah.
pumping, and I'm like, oh, keep going.
Pump.
You'll
Yes.
lose it.
There were at a babying company. The lactation consultants are doing a lot of referring out for frenulotomy, like they're having a lot of tongue tied, and so they're clipping the tongues, which is kind of a new thing too. I've not really seen that either until recently. So, if the baby's, and I'm not talking about a tongue tie you can see, it's only they can see it, like, because they know what they're looking for, not an obvious tongue tie.
Right.
So, checking bilirubins, like, every day pretty much until those start to come down. Once the bilirubin starts going down, it usually just continues to trend down. So it's not something that you have to, check in a week. If it's coming down, it's going down.
So if they're at like moderate risk, and they really want to try put them in the sunshine, yada yada.
Mhm.
I'll say come back the very next day or wait.
I usually go the next day, because you need to remember that the bilirubin, if it's trending up, it can jump up pretty quickly. But if it's trending down, then it's usually their feeding pattern is established, and they're probably good to go. And so then I might do like a 3-day follow-up after that. But so if we do one elevated one, I usually bring them in the next day and just make sure. The other thing you need to remember is if you weigh them naked one day, and then the very next day you weigh them and they've gained, 4 or 5 ounces, they're getting a good amount of milk in. You can also weigh them, have mom breastfeed, and then weigh them again right there in the office and see exactly how much they're getting. So we're kind of a little bit looser about, they don't start phototherapy until the numbers are higher than it used to be. And then transfusion, that's usually way down the pike. And that's usually, more than anything, it's for babies that have like an ABO blood incompatibility that wasn't picked up during prenatal care.
18 or 19?
Yes. Yeah, it's like 18. It's definitely over 17, 18, 19. Mm-hmm. Before we're talking about transfusing. So
that's the main things I see.
Yeah. And I don't know what you guys are seeing in clinical practice, but I swear jaundice is one of those things where wherever I've been, it's handled differently. Yeah. And so, and I've been with pediatricians and practitioners that are like, and then I've been with some that are like, we need to do, stat Billy and bring it back in 12 hours. And so we need to follow kind of the protocol with that. So, and again, I was telling Melissa this in clinicals this week, that little algorithm book, the pediatric clinical decision-making book, it really, when you guys are out on your own, it can be your best friend, because you shouldn't have to guess at all these things, because there's evidence-based protocols for all of them. So it really kind of helps take out a lot of the guesswork. So you got a child with a fever, look at the fever protocol. It'll say if they're this old, if they're this old. And so that's really where all your case studies have come from, is that book. I mean, or at least they're in there where you guys can find them. So it takes out a lot of the guesswork. But
isn't that weird when we had
Yeah, and then we had,
We're on the right track.
yes, so Melissa and I had a failure to thrive one that we were able to look at and go, you just follow through the protocol nicely already, you know, the algorithm's written for you. And then it ends at, you know, draw this, draw this, draw this, order this, and that kind of helps you cover your bases and also helps you cover your tail, that you're not missing anything and not just kind of, you know, flying by the seat of your pants to do this random workup. So that's that. Also, one of those guidelines are also on those guidelines, the new clinical practice guidelines, it said that all children like ages 13 to 18 or something like that, I have to look again. I'll upload it, needed to be screened for HIV if I guess just if they're sexually active. But that's not something I've ever done. But nobody admits to me when they're sexually active.
And to do HIV, you have to have permission.
I know.
It's just not cool.
I know. So I need to look into that guideline. I didn't know if you guys had seen anything.
Didn't it have to be drawn on certain days and sent out on certain days?
Oh, I don't know.
But there's just a screening, maybe not.
I think
Versus
it does.
risk.
Yeah, because I used to do infectious disease with them, and I think only on certain times of course that's children.
Yeah.
Because it's a send out, it has to be done before 1 p.m. and
Oh, that's
so that it gets where it's going in places.
Well, since you did infectious disease, what other infectious diseases do we need to talk about?
Oh my goodness, it's been a long time. We saw a lot of osteomyelitis.
Mm-hmm.
We saw a lot of mono.
Mm-hmm.
And then we started seeing a lot of MRSA.
oh,
Yeah.
That's true.
So if you guys heard Sarah, osteomyelitis, MRSA, which a lot of times is what's causing the osteomyelitis, and mono for infectious disease. And we've covered, I tried to pick, you know, some of the things as far as the case studies and stuff that are more of the in-depth stuff, and for the student presentations. The mono one was really good, and the take-home message for mono is that Epstein-Barr virus is a wild card. So, I mean, it can cause, like, Allison? Yes, she did the EBV one, right? Like Allison pointed out, it can cause cancers, lymphomas down the road. It can cause chronic fatigue syndrome for a long time. I've seen kids out of school for 6 months from mono.
Another, because I've done some research on the Zika virus because of where I was going, and they're starting to show a link between the Zika virus and Epstein-Barr.
Really?
Isn't that crazy?
That is crazy.
So if you got a cute little girl that went to spring break, or you know what I mean, like all these mission trips, I don't wanna say
Yeah.
girl, but boys too, they can
Oh.
get covered in this.
That's odd. Wow. And then, yeah, MRSA, we're just going to have to follow as it evolves and see what we can, you know, what it responds to. Osteomyelitis, you know, anytime we have fever and bone pain, and just remember that it's so hard to treat osteomyelitis because it's hard to get enough antibiotics to the source of infection, and that bone will actually remodel itself over the infection. So the bone will start to heal itself and have a big, huge pocket of infection there. And so that's why it's such a big, bad, scary thing. And so that's why we need to watch cellulitis so carefully and hit it with big guns, especially when they're on the, you know, close to the bone like that. And osteomyelitis can pop up anywhere. I mean, you can have an infected mosquito bite that settles down into you've had a trauma on your leg at some point and can settle down there. So that's kind of a scary thing too. And then we had a thing on Lyme disease, so that was good. So we talked about Lyme disease. What about Rocky Mountain spotted fever?
Well, because that didn't last as long, but we did see some Rocky Mountain spotted fever. We saw some rabies.
Rabies, okay, yeah.
And then some TB.
Okay.
And although they had them on medication, Dr. New always said they're not contagious. So it's kind of against the whole thing.
Huh.
But yeah. And hepatitis, we saw quite a bit of hepatitis in these little kids that were I guess more than hepatitis positive than others.
Yes. So hepatitis, I've had one child that was born
Yeah.
with Hep C, and then it's probably more now, but this was several years ago. But with the more IV drug users we have, the more perinatal hepatitis C that we'll have. Even though it's not a super, super high risk, it's definitely a risk factor that they can transfer it. I'm not talking about the IV drug use. I'm saying that it can be transferred perinatally. So that's one thing to be thinking about with the high risk moms as well.
That's all I think.
Brittany, Nancy, do you have any questions or comments? I hate being a talking head, but I never see y'all, so I'm trying to tell you
I'm
everything.
tired.
I know. I am too. You know what? See, these people back here, this one, the one, Macy, raise your hand. She was up at 2 a.m. crying because her braces, something popped open, and so we've had a miserable. We none of us slept in our house either. It was one of those nights. But
Well,
I was committed to making sure we got together today. So, ooh, that sounds like a little yapper.
Brittany's quiet little house.
That's all I have for you guys. I just wanted to talk about labs and some of the infectious disease stuff, and I'll upload those on. Do y'all have any questions or comments or anything for me? No? Y'all are doing good with all of your quizzes. I know you're probably getting tired of getting on there and doing those, but it is.
I'd rather do those.
You rather do those?
Yeah.
Okay.
I do them any day over professional development.
Me too, Nancy.
Y'all love this course. You love that course. I like when people upload their scores and say, I could have done better, except I was I get those all the time from people, except I was doing my other class. Well, I passed it on along the lines there.
She is grading much more lenient,
I still need on my to-do list, and it's just really a formality. I was going to try to make some sort of little PDF flyer for your all's celebration, and it's on the 12th of August. Remember? 5? I think we said 5, didn't
We
we?
said 5 or 6, I don't remember. I know they were having a cookout before us.
Do we want to say 6? Move it to 6 o'clock.
I think it's here, though.
It's here. Yeah, here.
Who's having a cookout? Camp?
There's a cookout here, but I'm talking about our PNP non-pinning.
Our non-pinning celebration?
Our PNP celebration, August 12th.
Yes, I wrote it down for August 12th. I think we didn't know if it was, do you want to say
Yes.
6?
Okay. I think we had said 5, but I can't remember who
Yeah.
was requesting that. I think it might have been some of the out-of-town people.
Okay.
So
Well,
they
let's
could get
keep it at
That's right, so
5.
they could get-
But I was going to try to make some sort of little flyer that you could at least send to your peeps and things that are coming. And then portfolios, anybody, I know you're just trying to get those done. Anybody have questions or problems with those?
What's the drop dead date on that? What's our drop dead date on?
Drop dead date on the portfolio, it's week 12, by week 12, so it's like the beginning of week 12.
So this is week 10.
We're in week
So we got
10.
a week.
Two weeks.
No, this is week 10, so we got.
Really, by next Sunday, you're supposed to have it, because it says by
The
week
30th?
10, yeah.
No, the 20th.
Melissa, I think it's the 24th, but you can double check me.
Okay.
24th, yeah. Because I've got to get those knocked out and sent to Bristol so that you guys can be done. Oh, remember we have a final in here.
I know,
Don't forget that. And I'm going to try to release that final. The last day of this class is when is it, Melissa?
Well,
August 18th.
August 18th is your last day to do clinicals.
Yes.
Oh,
So I'm going to have that. I was going to try to release that. I'm going to release it next week by the 11th, and you'll have a week to complete it. But it's going to be multiple choice, just like you've been doing. And so it's not going to take you that long.
Are you going to use some of the questions from the?
I'll use similar questions, yes, because those are all the test type questions. Yep.
Someone's afraid of
Dr. Neal, is that just a completion grade or is that an actual grade you get?
No, that's an actual grade.
I was just making sure it wasn't like the other practice quizzes.
No, that one you actually are gonna, that one I'm grading, and so, yeah. Okay. Nancy, any questions? You good? You ready?
Yes, I think that I'm good. That portfolio thing, I mean, is it like, when y'all grade, are you all like, it just stresses me out. It's like, oh God. I know that I sent you something.
Yeah.
You said that,
Yeah.
that sounds right. That sounds okay.
If you totally miss the mark, then I'll send it back to you and you have another opportunity. But more than anything is to make sure you have enough of however many it says, however many examples you have to have, make sure you put all those in there.
Okay.
It says 4, put 4.
And we could use some more than one.
Yeah, and you can use the same one in different spots. You just think about the purpose. You're trying to prove that you know about health policy, or you're trying to prove that you know about blah, blah, blah. And just so you're putting supporting evidence in. Okay? All right. Well, I hope everybody's surviving the summer. Just holler at me. I don't think we'll get together again unless somebody tells me to and we need something.
Wow. Question.
Yes.
I'm going to a GAC, this Southeastern Genetics Conference next week
Okay.
with Dr. Han. Can I count any of those hours? You're supposed to say yes, because you
I already
did
asked.
those
Sorry, I meant to get back to the group. Yeah, no, because Dr. Neal says no, because.
Dr. Neal
direct
has
patient-
been
Dr. Neal's
informed
already-
that all clinical hours are supposed to be hands-on patient hours. So I have already really pushed the limit by doing the pharmacology and nap and stuff.
Then I
So.
can still count that.
Okay. All right. Well, if anybody needs me, holler. Otherwise, I'm going to end this meeting. Okay. Bye. We'll see you later. Finish strong.
Sorry,
Go Vols.
we got this. We got this.
You got this.
Hey, it's
Bye.
only 7:15.